Hi, everybody. Welcome back to our CCRN review. Good to have everyone here. Hopefully, you guys got an email about the change of date. I assume you did if you're here right now. So, thank you for joining and thank you for your flexibility with that. We're in conference season here at Archer Review, which means I am traveling all over the place, going to conferences and meeting students, meeting nurses and faculty. And we had a conference come up and realized that I will be on a plane tomorrow when this was originally scheduled. So again, thank you guys for being flexible. If this is your first time here, hello, my name's Rebecca. I am the CCRN instructor with Archer Review. If you're using Archer for your CCRN prep, then you've probably seen me before in the on-demand videos. But if not, if you're just joining us, kind of getting a feel for what Archer CCRN is like, welcome. And yeah, happy to introduce myself. So about monthly now, we do these question reviews. So we spend 30 minutes together and we go through practice questions that are similar to the CCRN questions. And this is just to offer another way for you to prepare for your CCRN. You're probably taking lots of practice questions by yourself. You're watching a lot of review videos. This is a interactive way to also, again, take practice questions, but hear the rationale and explanation live and interact with me. Which brings me to my next point. We will be going through these practice questions. Definitely ask me questions. Put your answers to the questions in the chat. That way I can see what are the answer choices that most people are picking. And then I can kind of tailor how I explain the information based on the answer choices that people are selecting. Okay, I'm going to talk a little bit about the CCRN in case it is your first time here. While I do that, if y'all want to put in the chat if it is your first time, if you're joining back, maybe you joined last month, what type of ICU do you work in? Do you have your CCRN scheduled already, or are you more so, again, just kind of starting to think about the process and joining us today? How many years have you been a nurse? All those fun questions. I love seeing who's here with us today, and that way we can get acquainted a little bit. Okay, let me just fix my screen a little bit here. Customize it. Okay, so this is our CCRN. So the CCRN technically kind of stands for Critical Care Registered Nurse. It's a critical care nurse certification. So what it is when you have reached 1,750 hours of clinical experience, usually done in about a year if you're working full time, you can sit for an exam and prove your critical care knowledge, and that is the CCRN exam. Now, if you're going back to school or thinking about ever wanting to go back to school for CRNA, for nurse practitioner, this can be a really good thing to have, the certificate in your specialty. And also, a lot of hospitals now are paying nurses more for being certified, which is absolutely how it should be. My hospital does that, and I'm super thankful for it because it's a lot of work to become certified. It's a difficult exam, and you should be rewarded for doing that step of professional excellence. Now, in order to pass that exam, when you sit for the test, it'll be 150 total questions, and you need 125 correct, or I'm sorry, only 125 of them are scored, and you need 83 correct to pass, which comes out to about a 67% score on the exam. Now, even with that, we saw a 72% pass rate last year, proving that it is a difficult exam, with about over a quarter of the people taking it are failing. And that is why here at Archer, we wanted to put something together to help nurses pass this exam. We really think it's an excellent way to increase, again, your professional excellence and support nurses as they work at the bedside, as well as if they're interested in going back to school. But even if you have no interest in going back to school, it's still an excellent certification to obtain. I know for me, when I did my preparation to become CCRN certified, my confidence at the bedside increased so much. I felt like just the preparation for the CCRN closed the loops on so many different concepts that I just had more confident conversations with providers at the bedside, more confident conversations with patients, patient family members, explaining different conditions. And I just really am an advocate for CCRN certification effective just because of what I saw that it did in my own practice. So if you are not using Archer Review for CCRN preparation yet, what we offer is a 1,000 question Q bank, actually a little bit more than 1,000 questions. We have over 13 hours of on-demand video lecture material that break down every single concept that you will see on the CCRN test plan. Now, if you know, the CCRN board just released a new test plan that launched, I think, on the 12th, November 12th. And really, the changes that they made were to the test plan percentages, meaning on the old test plan, you would expect that 17% of the exam was in the cardiovascular section. Now those percentages are adjusted a little bit, but the content on the exam is very, very similar. So our prep material here at Archer is still very much up to date and accurate for the new test plan. That's been a question that we've gotten quite a bit, which is an excellent question. They release a new test plan about every 5 years or so. So it was just time that it happened again. And yes, we still cover all of the content that is listed on that test plan. Like I said, just the amount of questions you can see per area have shifted just slightly. Okay, let's go ahead and, oh, I think, did I just do something? I don't know if you just got something weird on your your end, I think I might have clicked somebody. Um, but that's okay. Yeah, we should be all right. Okay, let's go ahead and get started here. I'm actually going to skip question one. It's not my favorite. If we've got time, we'll go back to it. But since we've got control over that, I'm just going to skip it. Okay, so I'll read the question aloud. And then, like I said, please participate in the chat. Throw your answers in there, whether you think they're right or wrong. I don't care. Trust me. It just allows us to talk through the questions a little bit more. So here's our first question. A post-op liver transplant patient is 6 hours out from ICU admission. Vital signs right now are heart rate of 110, blood pressure of 102/60, and a temperature of 99.2 degrees Fahrenheit. GCS drops from 14 to 10, and there's new asterixis noted. Lactate is 3.8, ammonia is 112, and glucose is 54. Patient is ventilated on SIMV with an SpO2 of 95%. What is the priority nursing intervention? And I'll read these aloud as well in case you're listening and not able to see. So A, administer dextrose 50% IV push. B, elevate head of bed and call rapid neuro response. C, prepare for a stat CT of the head. D, notify notify the hepatic team for ammonia management. Hepatology. Gosh, why was that so hard there for me? All right, what do we think? Hepatology. Yeah, that's right. What is going to be our priority nursing intervention? Thank you for dropping your answers in the chat, everyone. That is so helpful. Can't tell you enough. We're getting a couple different answers, which is never a bad thing. That means that we're hopefully going to learn something in this 30 minutes. If everyone just answers everything right, then we don't really learn too much. Okay, so the two answers that I saw most were D and A, which totally makes sense. When we're looking at this profile, we got a lot of information in this question, right? Lots of vital signs, a lot of different lab values, and a little bit of context on their support. We know that they're ventilated. We've got a post-op liver transplant patient. So we know that we're going to be looking at our liver numbers a little bit closely, and we've been given a few of those with that ammonia level. So like I said, the answers I saw most were D and A, D being notify the hepatic team for ammonia management, and A, administer dextrose 50% IV push. So the answer here is going to be A. We're going to administer that dextrose. Like I said, we're given a ton of information, and we are looking at a lot of liver labs. We know that ammonia is elevated. This patient absolutely needs ammonia management. But first of all, our priority nursing intervention is handling hypoglycemia. So that's what we're going to do first. We are going to give some D50 IV push to bring that glucose up. Now, we can see hypoglycemia from liver failure as well. This can worsen encephalopathy and even sometimes mimic encephalopathy. So while we also want to manage that ammonia that's happening from this hepatic encephalopathy picture, we also need to manage that glucose. And that glucose is probably going to kill our patient quicker than an ammonia level. Maybe not a glucose of 54, but if it were to continue to drop, right? Okay, excellent job, everyone. Let's keep on going. Here's question three. A lot of information in this question as well. A patient post hip replacement is 3 days post-op and suddenly develops the following profile here. Respiratory rate is 38, heart rate is 142, blood pressure 94 over 58, and SpO2 is 88%. The ECG is showing sinus tachycardia. ABG is pH of 7.46, PaCO2 of 29, and PaO2 of 58. CVP is 12, lungs are clear, and there's no chest pain. Lactate is 4.5. What should what should the nurse expect next? A CT pulmonary angiogram and prep for thrombolytics. B, start fluid bolus and trend lactate. C, administer furosemide and apply BiPAP. D, administer beta blocker for rate control. What do we think? And you can also throw in there, what condition do you think this patient is experiencing? And I'll talk a little bit more about that after this question. Good job, Lindsay. Okay, let's go ahead and chat about this one. So first off, can anybody put in the chat, what do we think this patient is experiencing based on the symptoms and the story that we see in the question? What condition? Could be. Okay, so I got one answer for fat emboli. Could absolutely be a fat emboli. Could be a um uh any sort of pulmonary embolism. It could be a DVT that has floated up to the lungs. So it could be fat, could be clot material. Either way, because of our patient being post hip replacement 3 days ago, we know that that's a huge risk. Fat emboli and that DVT moving into becoming a pulmonary embolism are huge, huge risks. And that is really what our vital signs are showing us. We've got an accelerated respiratory rate up to 38, accelerated heart rate. So our heart is struggling with the fact that there's something sitting in that pulmonary artery. We've got a little bit of hemodynamic compromise given that high heart rate and a mildly soft blood pressure with 94 over 58. And we're just not oxygenating as well, which makes sense with that SpO2 of 88 and PaO2 of 58. So lung sounds are clear. CVP is 12. We might have some fluid backup from that right ventricle struggling to empty blood into that pulmonary artery. So because of that, the nurse is going to expect a pulmonary angiogram, CT, and prep for thrombolytics. We are assuming there's a clot in the pulmonary artery given this picture, and we will need to bust that clot with some thrombolytics. Now, fat embolism might be handled slightly differently. This would be if we're assuming that it is a blood clot that has traveled to the lungs, which might be a little bit more likely given it's a post-hip replacement and we're 3 days post-op. That's really a sweet spot timing for pulmonary embolism formed from a DVT in the lower extremities. If it's a fat embolism, so we might still give thrombolytics, but sometimes we don't always manage it that way just because the fat emboli are typically not conjoined as one large, how would I describe this? Like one large clump of fat sitting in the pulmonary artery, like we see with a DVT. What we're normally seeing with fat embolism is really small fragments of fat that make it up to the lungs and block alveoli. So it's a little bit harder to manage, and we don't always see so much hemodynamic compromise with a fat emboli, though you absolutely can. Okay, great job, everyone. Let's keep moving. Question four, a little bit less words, but still a lot here. We've got a septic patient receiving antibiotics, and they're showing platelets are 45,000, INR is 2.3, D-dimer is elevated, and fibrinogen is 105. There's evidence of new GI bleeding, blood pressure is 90 over 60 and they're on pressors, urine output is 5 milliliters an hour, and the patient is confused. My goodness, this is a sick patient, right? What is our first intervention? A, administer fresh frozen plasma and platelets. B, stop all anticoagulation therapy. C, transfuse PRBCs for blood loss. D, increase norepinephrine to improve MAP. Couple different answers here. This is a bit of a complicated question, and it's a good one for when we talk about CCRN testing strategies. I like this question because there's a lot of things here that we would do. And that is going to be the case with a lot of our CCRN questions. A lot of the answer choices are going to be good ideas and things that we would likely do for our patients. And then it's choosing what are we going to do first. One thing I will say about the CCRN, as you guys continue to put questions in the chat, the CCRN is pretty different than the NCLEX in the sense that it is not trying to trick you. I always thought the NCLEX and NCLEX style questions were very tricky questions, and the CCRN is really it's a difficult exam. I'm not going to lie, it's a difficult exam. But there is a chance that if you go in feeling pretty confident about the content, that you should be able to answer the questions pretty well. But it is going to really suss out your ability to prioritize and intervene. And it's still, you will still get those questions that you're like, but I would do all of these things at once. Or I don't have enough information to really make my best guess. And that's kind of where this question goes, which does make it come across a little bit trickier. So the answer choices that I am seeing most are B and C. Stop all anticoagulation therapy or transfuse PRBCs for blood loss. So if we had received any inclination that this person was on a heparin drip or had received or is still receiving any sort of anticoagulation therapy, then that would be the answer. But because the question did not tell us that they are actively receiving anticoagulants, that is not the answer in this question. And I know that that is tricky for sure. Same with C. When we consider transfusing PRBCs for blood loss, I kind of want to see a number. What is our hemoglobin to justify those PRBCs? Now we have soft blood pressures. We've got things telling us we're not perfusing our kidneys great. We've got things telling us that we probably need to give this patient blood, regardless of what that hemoglobin is really telling us, because they're symptomatic of blood loss. But still, I want something a little bit more concrete. The answer here is actually A, administer fresh frozen plasma and platelets. What is the reason for that? What can we think? What in the question is telling us that this person needs FFP and platelets? Platelets are a little bit obvious. This kind of takes thinking about FFP. Sometimes I think, and I sense this sometimes when I'm precepting, we can view, yeah, GI bleed, absolutely. We can view FFP as like, oh yeah, you give it, every couple of blood product, every couple of packs of PRBCs, because we want to make sure we're giving the patient back. They're losing whole blood. We want to give them some whole blood back. But we also give FFP because it is chock full of clotting factors. And this patient is septic. What condition do we think that they're in? We've got a septic patient with really whack coagulation studies. They've got new GI bleeding. What condition are they suffering from? Yeah, totally. This is classic DIC. Classic DIC. So we need to give this patient clotting factors back. The other term for DIC that I really like is consumptive coagulopathy, meaning the reason for the coagulopathy is that we are consuming and using up all of our clotting factors, and we're sending microclots places, sometimes macro clots. And we're using up all those clotting factors. We have none left, and that is why this patient is now showing these signs of GI bleeding and is losing blood. We have desperately need to give this patient clotting factors back if we have any hope of this GI bleeding stopping. At the same time, we also will want to, depending on what that hemoglobin looks like, give some blood. We may need to increase norepinephrine to increase the MAP. However, I would rather give the FFP, give some fluid back, get those clotting factors, stop the bleeding, and raise our blood pressure that way. But we obviously will use pressors to buy some time in that scenario. So the answer here is going to be address that cause of the fact that this patient no longer has clotting factors circulating, and we really need more of those on board. Excuse me, FFP and platelets are going to accomplish that. Now, I think this question is still a little bit tricky in the sense that a platelet count of 45,000 does not usually warrant a transfusion of platelets. We usually wait until that number is quite a bit lower, sometimes under 20 or even lower than that. So I can understand that that would make this even more confusing. It's a difficult question for sure, because again, we would do all of these things. But because we were not told they're on anticoagulants, I'm not going to worry about B. I want a number to transfuse PRBCs for blood loss. And I want to increase my MAP for sure, but I'm going to do it a different way. I want to give fluids. I want to give FFP. I want to give blood if that number shows me that I need to, in addition to the whole clinical picture of the patient. But here, the question is wanting to recognize this person's in DIC, and therefore they have no clotting factors on board. All right, good job, everyone. That's a difficult question for sure. Lots of different layers to that one. Okay, let's continue here with question 5. A postpartum woman with chorioamnionitis undergoes emergent C-section with epidural. Post-op, she develops a heart rate of 52, blood pressure 72 over 40, respiratory rate is 8, and SpO2 is 91%. She has flaccid arms and is unable to speak. What is the priority action? And again, if you want to throw in what condition you think that the patient is experiencing, can do that as well. Okay, so the answer here is going to be D, prepare for immediate intubation and mechanical ventilation. What do we think is going on here? Can anyone tell me what they're guessing is going on that would lead us to going to D? Because there's a lot of different things we could do with that set of vital signs, for sure. And this is a very common format for CCRN, where they're going to give you this, a set of symptoms, a set of vital signs, some lab values, describe the patient story, and they're not going to ask you necessarily. I mean, they might. There's going to definitely be questions that are a little bit more straightforward in this way. But for the most part, they want you in your head to say, I think this person's experiencing this. And that is why I'm choosing this as my priority action. And it's going to have that actually be the question is what is your priority action? And that's why when I'm giving test taking tips for the CCRN, I say read the question and don't read any answer choices. Start to paint a picture in your mind of what you think that patient's experiencing and what you would do in practice. And then read the answer choices. Because for one, a lot of the answer choices are going to sound good. They're going to sound like great ideas. And two, if you don't feel really confident about what you think is going on with the patient, the answer choices can get really distracting because again, a lot of them are going to sound like great ideas. So here, what we think the patient is experiencing is high spinal block. This is a postpartum woman. She just had emergency section with an epidural. High spinal block is when that medication that is supposed to go down lower in the spinal cord starts to leak up the spinal space. And we actually cause those spinal block symptoms higher up in the spinal cord. And that's why we're seeing a respiratory rate of 8. We are shutting that respiratory system down. Flaccid arms and unable to speak. They have paralysis higher up on the spinal cord than what would be wanted or desired when getting an epidural, but it's definitely a complication that can occur with epidurals. So because of that, because we're seeing this respiratory rate of 8, remember respiratory rate below 8 is intubate, GCS below 8 is intubate, then we are going and unable to speak. We are going to intubate and mechanically ventilate, and then we can start to worry about those other vital signs like our heart rate and blood pressure. And that's when we might think about atropine, think about norepinephrine, and go from there. But that airway emergency is the top priority given what we think the patient is experiencing. Okay. Somebody said PE as well as like an option for what this patient is experiencing. Absolutely could be a option. Anytime we've got a post-op patient, we're thinking PE. We've already seen that in questions previously. So absolutely. The only thing I would say that would maybe rule out PE is that our heart rate is 52. Pretty much every time we have a pulmonary embolism, we're going to see that with tachycardia. And usually an increased respiratory rate as well as the body tries to compensate. So those two vital signs kind of rule that out. And that's the other thing I would totally suggest as you're taking these questions. Take whatever thought comes to mind and then compare that thought to every single piece of information that the question gave you and see if there's anything that rules out that initial thought. Okay, we've got time for one more. So let's do this one here. This is kind of in a different vein. A patient presents with a glucose of 1100, sodium of 128, potassium 5.9, creatinine of 3, pH of 7.38, and there's no ketones. Osmolality is 360. Mental status is altered. What is the first priority intervention? It's been the kind of the tail of all of our questions. A, initiate insulin perfusion per HHS protocol. B, begin large volume fluid replacement with normal saline. C, administer IV potassium to prevent shift. And D, restrict fluids due to renal dysfunction. Couple different answers here. Okay, so the answer here is going to be B, begin large volume fluid replacement with, with normal saline. Normal saline's a good choice in HHS because we typically are seeing this lower sodium count, so we're safe with normal saline. Lactated ringers also works. The other answer choices that we could think about, we've got a massive glucose here of 1100. Again, what condition, somebody already put it in the chat, but what condition do we think this person is experiencing? We're pretty much between HHS and DKA, right? What tells us that it is HHS? There's a few little notes that would tell us this is not DKA. Yeah, we are not seeing ketones in the urine, and we are also not acidotic. We have to be acidotic to be in DKA. And we have a normal pH, which tells us there's no acidosis going on. But again, similar conditions, right? We've got similar management of these conditions. So we've got glucose of 1100, which is hugely high. I'm thinking, oh my gosh, I want to start insulin ASAP, but we're going to do something more than that. We're going to do something else first, and that is going to be large volume fluid replacement. The osmolality is really, really high. We have to rehydrate this patient. That is what is going to hurt them first is dehydration versus that glucose of 1100. So, and usually those happen, we think about getting this patient into the ER or directly into the ICU, and we are usually doing these things at, again, a very similar time. But when I see this patient come in to the unit, I am thinking fluid first, especially because fluid's like a lot more accessible than waiting on insulin from pharmacy or getting it from the Omnicell or Pyxis. We're going to start with large volume fluid replacement to help that dehydration. We really need aggressive fluid resuscitation. Now, after that, we'll absolutely start an insulin infusion as well. We are not going to restrict fluids, which I don't think anybody said, so good job. Absolutely not going to restrict fluids. And then we did have one answer for administer IV potassium to prevent shift. We will usually not give potassium until that number tells us that the patient actually needs it. Until we're below that 3.5, or for some protocols, maybe below that 4.1 range for potassium, we are not going to administer potassium just out of prevention. Potassium is obviously hugely dangerous. It can stop your heart if that number gets too high. So we're assuming, when we start insulin, yes, we will expect to see that potassium decrease, but we want to wait until we actually see that decrease before giving potassium. Okay, good job, everybody. Excellent job today. Here is our QR code for the next webinar, which will be in December. If you guys like this style, if this is helpful for you to go through questions kind of in a live format like this, we stream all of these webinars to YouTube. I do repeat some questions from like 6 months ago, so you might see some repeats in there. But if this is helpful for you, go to YouTube. Just search in Archer Review CCRN. There's a whole playlist of videos just like this one, if this is a helpful format for you. If you would like to sign up for our next webinar, here's the link, here's the QR code, and there's the link in the chat. Thank you guys so much. Let me know if this was helpful. If there's anything you want to see from these in the future. Sometimes we do more content heavy ones. I've done a mechanical ventilation workshop, PA catheter crash course, ECG crash course. Again, those are on YouTube for you to find at any time as well. Thank you so much, everyone, for being here. You're welcome. We will see you in... Oh, there we go. See you in a few weeks for our December CCRN webinar. Okay, bye everyone. Good